Okay. Hi, everyone, and welcome to the first Community Table learning series for the new year of 2023. I hope everyone's new year has been healthy and restful. Um, we want to thank our sponsors, Anthem Medicaid, for allowing us to host this wonderful learning series. And we also want to thank Miss Cindy Manginelli from the National Healthcare for the Homeless Council for joining us today and being able to speak to us on this important topic of substance use and homeless services. We are going to let Cindy go ahead and get started. We have 1 hour today to be with Cindy. And Cindy, if you want to go ahead and go on with the presentation.
Absolutely. Hello, everyone. It's good to be with you today and to talk about this important topic. Again, I'm Cindy Manginelli, and I'm the Director of Community Engagement for the National Healthcare for the Homeless Council. If you're not familiar with the Council, we are a national training and technical assistance program, primarily offering training and technical assistance to those who provide healthcare services for people experiencing homelessness. But we also do a wide range of trainings like this, just for people on all different, whether it's professionally or personally, or people who are interested in helping those experiencing homelessness. And so if you go to our website, which is NHCH.org, you'll see all kinds of resources on all things imaginable at the intersection of healthcare and homelessness. So I would encourage you to do that, to check us out. And I think you'll find a lot of things there that will be helpful. But today specifically, we're going to talk about substance use and homeless services. My background before coming to the council is primarily indirect services. I worked in church for a long time and did women and children's ministry and worked with people in crisis. And then I was a counselor in a domestic violence shelter for several years. I was the director of medical services in a detox unit for a while, working with women who were coming out of incarceration or women who did not have insurance, a lot of women who were homeless but seeking treatment services. A lot of what I'm going to talk about today comes out of that experience, but also just since joining the council, we talk to shelters across the country that are trying to figure out what to do to serve those who struggle with substance use. And I know even right off with a topic like this, that for many of us, this topic is a personal one, is one that really means something in our personal life. Some of those listening to me today may have substance use may be part of your story, either directly in your own life or through the life of someone you love. Certainly, we've probably all served people who struggled with substance use or for whom substance use was part of their story. And we can have a wide range of feelings, even just when we say substance use. And so I just want to acknowledge that first off. It's a hard topic to talk about. It's a hard topic to figure out what's the right word to use. We're going to talk about that. I'm not going to be telling you today what you should be doing, what sort of policies you should create. This is not going to be a prescriptive training because I don't know what you should do, to be honest. That's really up to you and your mission and your leadership and the people you serve and your goal and your mission. What I am going to do today is we're going to talk about the things that we have to think about, the things we have to talk about if we're going to consider how we reach out to people who struggle with substance use. That's really what we're going to do today. I hope you leave today with a lot to think about, a lot to talk about with your team, with an administration, with your board even, to think about really practically how do we best serve those struggling with substance use, and while also serving everyone else who comes through our program. So this is going to be that kind of discussion. I think it's going to be really practical, but I also want to acknowledge that it's a hard topic, and we are going to talk about it very honestly, just very frankly. And so I want to say right off at the start here that that's not because I'm unfeeling about it. I really am hoping that we can talk about it in sort of an academic way that kind of keeps people from really feeling it. But I recognize this is a hard topic, and we have a wide range of emotions as we talk about it. So to that end, let's kind of talk about the complexities of this conversation. Several years ago, as I mentioned, I was working in a domestic violence shelter in Nashville. I'm in Nashville, Tennessee today. We do national work, but our office is in Nashville, and I've lived in Nashville my whole life. And we have a domestic violence shelter here. We would serve about 50 women and children. And we were kind of struggling with this policy around how we best serve people who were using substances. And to be honest, we were very inconsistent, and it kind of depended on the staff that was there and how they interpreted very vague policies and procedures. In some ways, maybe that was helpful, and in some ways it definitely wasn't. But we had a night where I was working the 4 to midnight shift, and we had a young woman come in, and she had been staying in our shelter for about a month. Her name was Heather, and Heather had been engaged in sex work. I think she was 22 when she came to shelter, and I think she had been engaged in sex work already for 5 or 6 years. It had been the only work she'd ever known since her childhood, really. And she had a client who had become extremely violent and was stalking her. I mean, just cruel kinds of things, and it really scared her. And the police had referred her to our shelter. She'd been with us for a few weeks, and even just in that short period of time had decided that she was going to enroll in community college classes. She decided to pursue a different line of work. She'd made some major lifestyle changes, and in her mind she was on a path that made much more sense to her and that she felt much better about. So this felt like significant progress to her. So she came in late one night and she said, my grandmother died, and I went to the funeral, and I drank a lot, and I'm drunk. And I used some marijuana, and I don't know what else I did, but here I am. And I don't have any of those things with me. I'm not going to do anything else. I'm just going to go to bed. And she didn't have any signs of overdose or anything like that. She looked exactly like she described herself. And we said, okay, well then just go straight to your room and go to bed. Our rooms held 2 people each. About 15 minutes late, her roommate Shannon came down to the office, and Shannon said, I've been here for 3 days. I came here directly from treatment. I just finished 3 months of intense inpatient treatment. I was court ordered. I'm on parole. I have to be drug tested every week by my parole officer. And my boyfriend just got out of jail yesterday. He's looking for me to kill me because I testified against him when we were both, sent to court for using. I just need a couple of weeks with a place to stay, and then I'm going to go out of town and I'm going to have a place to live. But my roommate's in my room, and she reeks of alcohol and she reeks of marijuana, and I can't do this. I've been out of treatment for less than a week. There are issues like that that I think when it just really comes down to the most practical elements of this conversation, I think it's situations like that that prove to be the most complex for those of us who are serving people experiencing homelessness, especially in day centers, shelters, places like that. Who's wrong in that situation? Who deserves shelter more, right? How do you possibly decide who has the better case, right? Our mission was to provide a physically and emotionally safe place for women experiencing homelessness as a result of domestic violence. We wanted to do that for Heather. We wanted to do that for Shannon. How do we do that for both? Can we do it for both? If we can only do it for one, which one? These are the kinds of conversations that I think take place all over the country all the time in this issue of substance use, and really kind of come down to kind of the crux of this conversation. I've worked with programs who would have looked at Heather and said, you know what, Heather, you made the decision to use, you know that we don't allow that here, and so you've made a decision in essence not to stay here. I've worked with programs who would have looked at Shannon and said, Shannon, we are tolerant of people regardless of whether or not they use substances. We support them and providing shelter for them, and we don't judge their behavior. If you can't handle that, then you're not able to stay here. And then a whole lot of responses in between. So that's what kind of the foundation of what we want to talk about today is these are conversations that we have to have if we're going to serve people experiencing homelessness who are also experiencing substance use. What are the things that we have to consider? What are the things that we're trying to balance? And I think balance is an enormous part of this. I'll go ahead and say too, and I forgot to mention this at the beginning, we are going to have time for questions. If you have a question, feel free to type it in. I will not be necessarily looking at those until the end, but I'm happy to be interrupted too. But if you have comments, questions, feel free to put those in. But that's what we're going to be talking about today. So we have to balance in all of this our own personal experience with substance use, how it's affected our lives, how it's affected the lives of those that we love, what we feel, our knee-jerk reaction when we think about substance use, our mission and our underlying desire to provide a physically, emotionally safe place for people, The desire to avoid making anyone feel punished or trying to punish anyone, mixed with the desire to have people sort of experience the consequences of their behavior. And that sounds harsh, but I think that comes up in the conversation a lot. And I think also we all do want people, we're not trying to create some sort of distorted world where people can do whatever they want and there's no consequences. We know that's impossible. So we're trying to balance all of these things. Our feelings of empathy, you may feel anger when we talk about this. There's a lot of misunderstanding around this and why people use, and does that matter? It's a complicated issue. And these are all things that are going to be part of the conversation, whether you're having kind of the conversation in your own mind, or you're going to have the conversation with your team or your funders or your board. We have to be really forthright with the fact that these are all feelings that could come up, and that's natural. That doesn't mean it's wrong, right? There can also be a lot of transference when we talk about this, meaning that I look at the client that I'm serving and I imagine that they are experiencing substance use the same way I did, or the same way my child did, or my parent did. This is a topic that most of us, that if you've had experience with this, it could be something that really framed your whole life. And we can transfer our own feelings, our own experience to other people. So all things that we have to keep in mind as we think about this conversation. When I was working in the detox unit several years ago, we had a young woman come in, and she had really no experience in alcohol use or substance use at all until she was 25, when she went through, she'd had a difficult childhood, a pretty traumatic childhood. She'd graduated from high school, moved away for college, fell in love with someone, had a baby. The baby, after the baby was probably, I think maybe 3 or 4 years old, her husband was killed instantly in a car crash. She was also in the car, and she suffered tremendously, a lot of physical effects as well. She had to have several surgeries, and she was prescribed prescription pain medication. And when she got out of the hospital, she had her little girl who was about 3 years old, and it was her and her little girl. Her family lived on the other side of the country, and she didn't have very much contact with them. She had a brother who she had some contact with, but he was in the military and was not able to be real supportive. She began taking this pain medication and really felt like, for the first time, she felt normal. It took care of the pain, which was considerable, but it also took care of a lot of the anxiety that she was feeling, and it made her feel more confident. It made her feel more under control. So she ran out of the prescription. She began to be aggressive about seeking other providers who could write the prescription. And she began to suspect that she had become dependent upon this medication, but she just tried not to think about it. Of course, she was grieving. Life was really hard. Eventually, she kind of went through a number of providers, and she began to take prescription medications from her customers. She was a housekeeper, and so she would go into people's houses and clean their houses, and then she would take their medication too. Eventually, she was caught on camera, and her client turned her over to the police. She went before a judge who said, we will do court-ordered treatment, and if you finish this 1-month program of treatment, you won't go to jail. Everything will be fine. But if you don't finish this treatment, you're going to go to prison, and you're going to lose custody of your daughter, and that's going to be it, because she'd actually stolen a considerable amount, and it was going to be a big offense. So she came to our program. When she came to our program, she found her bed in the detox unit, and she put a picture very much like this picture here next to her bed. And she talked about her daughter constantly. She had artwork that her daughter had made hung all around her bed. Her daughter was her life. And the only time she would smile was when she was talking about her little girl. She was there for about 2 weeks. Her brother had received a special permission to come home and care for her daughter, but he was going to have to go back to active duty as soon as she was done in a month. About 2 weeks into her program, she came downstairs and she said, "I'm leaving. I can't do this." She had called her brother to come get her. Her brother came not to pick her up, but to beg her to stay. He said, "You have to stay." We didn't typically do much to persuade people one way or the other. A lot of the people that we were working with, much like a lot of the people that you're working with, feel very manipulated, have been very manipulated. They feel powerless. And so we tried to make sure that our clients were making their own decisions. But we did say, as we were required to with court-ordered participants, if you leave here, we have to tell your parole officer that you're gone and you're going to be arrested. And you're going to go, if the judge does what he said he's going to do, you're going to go to prison. And her brother said, if you leave, you're going to lose custody of your little girl. You may never see her again. I can't stay here and take care of her. Are we going to ship her on the other side of the country with people she's never met to have an upbringing like we had? Is she going to go to foster care? And with tears streaming down her face, she said, I'm not staying here. And she left. I had many conversations like that when I worked in the detox unit. It was one of the first times that I remember kind of realizing that you could use substances and they have and it is possible, not always, but it is possible for substances to have such a profound effect on your brain, that substances can have such a profound effect on your will, your emotions, that it is possible to want to feel that you need something so uncontrollably that even your most basic instincts of self-preservation, of freedom, the maternal instinct, even the desire for everything else that has been so important to you that you framed your whole life around, can disappear. I had not realized that before that. It shaped a lot of what I think about substance use, that it is possible for a substance to become so important to you that you lose all sense of everything else that's important. I think it's important to realize as we talk about this topic, that this is more, and this is more true now than, as far as we know, it's ever been, because the substances that people are being offered and that people are purchasing and that people are taking today are stronger and have a more addictive component than substances even that were on the street 5, 10, 15 years ago. Even the marijuana that people are taking today, according to the Overdose Prevention Society, is not the same marijuana that people were taking maybe even before the pandemic. And so substance use, addiction is a real thing. And we have to keep that in mind, and we have to think about that. Again, I tend to be very much about free will and very much about you make a decision and then you walk through the consequences of what that decision calls for or leads to. And then even in direct services, I think that's kind of a principle. I think that's something that we have to recognize, but we also have to recognize the quality of what people are taking and how it can make people feel, and that substance use can't override someone's every other instinct, every other impulse that someone has. So as we talk about substance use services, one of the hardest parts about this conversation is, what words do we use? And to be honest, I did this training, I think it's been 5 or 6 years since I've done a full training on this, I guess, because the slides I found, even some of the words in the slides from like maybe 4 years ago had to be updated and changed. So when we talk about substance use, one of the reasons why a lot of people struggle to talk about it is because we're not sure what words to use. And I think it's better to jump into a conversation and struggle through the words rather than to avoid talking about it at all. But I do think people do avoid talking about it because of that. So is substance use a disease? Is it simply a behavior, simply a choice? Is it always addiction? Is it a disorder? When we talk about someone who struggles with substance use, can we say it's a struggle, or do we just say it's a lifestyle or a choice? Do we call that person an addict or simply a client or a patient? Can we talk about someone as experiencing recovery or sobriety, or that someone is clean? These are hard questions and constantly changing questions. We, of course, do a lot of publications and trainings on these topics. And so for right now, based on information that we receive in community information within the field, we are using the word substance use to describe all kinds of substance use, whether someone is using recreationally or whether someone is would actually consider themselves to be addicted to a substance. We know that several years ago, when insurance companies started paying for treatment services, addiction had to be classified as a disease. It had to be given a medical diagnosis. It had to be given a code, basically. And so we started talking about addiction differently, but also a lot of people have found it really helpful and really therapeutic to talk about and to think about substance use as a disease based on the way your brain changes the way your brain responds, the way your body responds, sort of that compulsion, that overriding desire and impulse that we just described in the story with the patient I was talking about. But to be honest, there are many people who use substances who find that to be very unhelpful. And almost any time I do this training in person, I will have someone who says, you know what, I'm an alcoholic and I call it alcoholism, and I don't appreciate the idea that I have a disease. And my response is always, absolutely. I think we have to allow people to talk about what they're experiencing in the words that are best for them. And so I know some programs don't. I know some programs would respond to that person and say, no, you have a disease. And it's sad that you don't know how to think about that. And that's up to you how you do that. But whatever language you pick, it's important to realize that you will have people who come to your program who don't find that language to be helpful and don't identify with that language. Many people find it helpful to think about addiction as a disease. Many people find it helpful to think about addiction as a behavior, as a choice that they make. Sometimes people find both to be helpful. So it probably would be helpful for your agency to decide how you talk about it, what language you find acceptable. A lot of times funders will mandate certain language. And the language that we're using is what is primarily mandated by the federal government, and that is to talk about substance use in those terms. But you also need to probably give room for your clients and how they choose to talk about what they're experiencing and what they experience. When we talk about people who are in treatment or people who have used substances who are choosing not to, we do find in the field that it's fine to use the word recovery, to use the word treatment. We are less and less using the word clean. A lot of people felt like to talk about someone as clean meant to imply that those who were using were dirty, and that's not the language we wanted to use. I'm hearing the word sobriety less and less as well. But as far as on a professional level and academic level, certainly we will talk to people who consider themselves to be walking in sobriety and find that language to be really helpful. But recovery is still a term that is used widely and that still seems to be neutral and not offensive in a professional way as you talk about it among your staff and with your funders. So as we think about these terms, the word use, the word abuse, the word addiction, these are different categories that some agencies find helpful, some do not. Some don't make any distinction whatsoever, but some agencies find these classifications to be helpful. That use would be someone who is using a substance for its intended purpose. And that's hard to quantify. But if I have a client who comes in and they have Valium, and it's because they've been given a prescription for Valium, or perhaps they're taking Valium and they don't have a prescription and it's not, it wasn't given to them by a physician, but they are using that Valium in a way that would be considered appropriate, right? Regardless of how they found it or why they have it, that would be considered substance use. Substance abuse would mean that someone's coming in and they have Valium, but they are using it beyond what would be considered appropriate or healthy. And again, that's very hard to judge. What is an appropriate or healthy or normal use for cocaine? There are people who would say cocaine is fine to use recreationally and in certain amounts. There are others who would say cocaine is never appropriate to use. Any use of cocaine is abuse. These are difficult conversations as well. But some people would use these classifications and say abuse means that the substance is being used in a way that is unhealthy, that is dysfunctional, that is inappropriate. It's affecting that person's behavior, their ability to function, their ability to cope. And then the third category being addiction, where there's a clinical definition for addiction. It can vary some, but it basically involves where I'm using a substance, whether that's alcohol or a prescription drug or an illegal drug. I'm using a substance, and when I stop using it, I experience withdrawal. I may be grumpy, I may be agitated, I may experience physical symptoms, but I can't stop using it without feeling consequences. I feel dependent upon the substance. I feel like I can't function without it. I'm developing a tolerance for the substance, so I use the substance regularly, and I have to use it more than I did this time last month or this time last year in order to have the same effect. My behavior has become uncontrolled at times. It's affecting my social environment. It's affecting my relationships. I feel like I can't control when I use it and how much I use. And then I'm willing to take risk in order to get more or in order to keep taking it. And there are more robust definitions of addiction, but some agencies find it helpful to think about how they respond to people, whether they're using a substance, abusing a substance, or addicted to a substance. Some do not, but this may be part of the conversation that's helpful to you. We're not going to spend a whole lot of time talking about the causes of substance use, why people use substances. We're not going to spend a whole lot of time talking about how they get substances and how they choose what substance that they take. We're not going to spend a whole lot of time talking about specific substances. But I think it may be helpful to spend just a few minutes talking about these things. According to SAMHSA's, 38% of people who are homeless, when they did a poll, I believe this was in 2021, 38% of people who were homeless reported that they abused alcohol or described alcohol use that would be classified as abuse, and 26 described behavior that would be classified as drug abuse. This is just of people who are homeless. So that would be a significantly greater part of the population than we would expect to see in the general population. Some research would indicate, the American Addiction Center said that research would indicate that about 1 out of 3 people who experience homelessness are also abusing drugs or alcohol, again, using the definition of abuse that I just gave. The problem here is this because, was this the cause of their homelessness, or are they using substances to cope with homelessness? And none of this research really reflects that. We tend to see someone who's experiencing homelessness who is clearly intoxicated or clearly struggling, clearly under the influence of substances, and assume, well, that's why you're homeless. But as we talk to people who are experiencing homelessness, we very often find, no, they were homeless for 5 years before they ever took a drink, or they were homeless, this is not the cause, this is a consequence. And so for this reason, data around homelessness and substance use can be really confusing and hard to kind of sort through. We know that the #1 cause of homelessness is poverty. We know that. We know that the second primary cause of homelessness is family conflict. The third is medical issues, whether that's mental health or physical health. And we know that with each of those things, certainly people can use drugs and alcohol to cope with those things. So it's very difficult to tell which came first, but I do believe it would be a very strong assumption to say that even when we engage people who are homeless and who are using substances, I think it is inappropriate to assume that that is why they are homeless and to make blanket assumptions like that. Certainly there are people who have a genetic predisposition for substance use. We know that people will use substances for pain management, both emotional pain and physical pain. When I worked in the detox unit, many of the people, I think at one point when we did a report, we just determined that as many as 1/3 of the people who were there receiving treatment had started taking drugs because of pain. Something hurt. Crisis and stress, we talked about, like with Heather, and adverse childhood experiences, different things that we've experienced or struggled with can certainly lead to substance use. Dealing with trauma and stress in the moment, our environment, and being in an environment where everyone is using, or where it's considered normal to use, or using is the primary way that people cope. It's important to think, when you think about assisting someone or working with someone who uses substance, to realize that ritual is sometimes a huge part of the appeal of substance use. I've worked with people who've used substances for years, and their whole day was structured around, where am I going to get it? When am I going to use it? Where will I be? What will I do afterwards? And there's a ritual to it. You've probably seen this too with clients that you've worked with who smoke. I get up in the morning, I smoke. After every meal, every time I'm stressed, that it's just the natural go-to, and that smoking is a huge part of their day. And certainly substance use can be the same way. A lot of people, their peer group, the primary way that they gather with their peer group is around substance use. And so their friendships, their sense of community is linked to their substance use. And then for some too, it's just a part of their lifestyle. That's just when I party, when I'm happy, when I celebrate, when I'm sad, when I'm depressed, this is how I cope. That's just how I live. All parts of the substance use conversation. Again, we're not going to spend a lot of time on this. This used to be when I did this training, I spent a lot of time on this, and we would talk about, okay, what did the person take? How are they going to respond? What's the risk based on what they took? And the whole training was kind of based on this. What did they take? Here's the risks associated with that. Here's what you can do. Here's what you can expect. We don't do this anymore. As I mentioned, the Overdose Prevention Society has pointed out that more than ever, when people buy a substance or use a substance, they are unsure as to what they're getting. Here in the state of Tennessee, I cannot remember the figure. I just talked to someone from Overdose Prevention, and they were saying that something like 30% of the marijuana, of the simple street marijuana collected by law enforcement, contained traces of fentanyl. And so I don't do this part of the training anymore because I find that we don't really know what someone is taking. It seems to me like it's becoming more and more rare for someone to be taking a substance and it's just that substance, and that even the clients that we're working with are not always 100% positive of what they're taking. And so I think it's a little pointless to spend a whole lot of time investing in, okay, this is how they're presenting, so they probably took this, so these are the risks. And I just find that we just can't invest a whole lot in that anymore. We had clients in the detox unit who would come in. I remember one client who had used marijuana for 5 years. She always has the same buyer. The buyer was a family member, always bought the same amount. She always had the same response, that was just part of her life. And she came into the detox unit. She was living in our transitional housing program. She came into the clinic, and her arms and legs were flailing. She could not control them at all. And she was completely out of control. Mentally, she was fine, but she could not control her body parts. She had to be strapped down. And she'd gotten the same marijuana dose from the same buyer. He was like 2 steps removed from the grower, and there was something in it. There was LSD in it, and we're finding that more and more. So we don't spend a whole lot of time, and I don't think it's worth investing a whole lot in the list and the different side effects anymore. So how do agencies that serve people experiencing homelessness respond to clients who are using substances? There's a wide range of different responses. I've made 3 categories here. Which one should you do? I don't know. That's really based on your program, your mission. We'll talk more about that in a bit. So I am not really advocating for any one of these. What I'm hoping to do is to present to you the options and why people choose what they choose. And we're going to talk more about this as we move through. So there are some programs that are very restrictive in nature and who really have a zero tolerance policy, meaning that when you come into our program, whether that's a day center or a program that's providing meals or shelter, if there's any evidence that you are using, you're out. You can't come if you have clearly been using substances. A lot of people, some will actually drug test. And you can do a urine test, you can do a breath test. Some will even do a blood test. That's a little more rare, but in general, and to be honest, testing in general is fairly rare. But some will test, others will just look for physical symptoms. If you smell like alcohol or a substance, if your pupils, are dilated or really large, if if your eyes are red, if you're slurred speech, if you're behaving as if you're intoxicated, then you can't come. Some of those shelters would report those people to the authorities. Some would dismiss that person and tell them they can't receive services ever again. Some would say, would identify a probationary period. Some would say you just can't receive services today. Some would dismiss the person from their campus and that would be it. Others would dismiss the person and then alert the authorities. Sometimes people will alert the authorities based on the behavior, if they believe the person's going to be a danger to themselves or others. If someone brings drugs or drug paraphernalia onto the property, some programs will confiscate that and turn it over to the authorities. Some will turn it over to the authorities in an anonymous manner. Some will turn it over to the authorities with a report form from whom they confiscated it. Others will just say you have to take it and go. But certainly there are programs that feel like we cannot serve someone who is under the influence of drugs or alcohol, or who has drugs or alcohol in their possession. Others operate in sort of a middle of the road kind of way, that if there's evidence of recent use, but no active use, the person can still receive services. So if, much like I mentioned in the story at the beginning with Heather, Heather clearly had been using, but she didn't have any drugs on her. She didn't have any alcohol on her. And she was not in any way a danger to herself or others, as far as we could tell. So she was allowed to stay. And so we basically made those decisions based on how the client presented to us. Are you presenting as someone whose symptoms, whose behavior we can manage? The same way we would if someone came in and said, hey, I have unmanaged severe schizophrenia. This is how I'm feeling today. Okay, we can handle that. We can work together. We can make a safety plan, right? And you can stay. The same way we would have someone just based on their behavior, regardless of why they were acting or feeling the way they were acting or feeling. Some in this situation would have a sober room. I've heard it called a sober room, but basically some area, it could be a quiet room, but some room or area where someone who is under the influence of drugs or alcohol can go and basically be separated from everyone else. And so if maybe because of the symptoms they're experiencing, or maybe just so that no one else is triggered, much like we mentioned in the story at the beginning, if we had a room like this, we actually did, but it was full, the shelter was just overflowing, but we would have encouraged Heather to go and sleep in a room by herself. And that way Shannon would not have been impacted by Heather's drug or alcohol use. And so a separate area where people can go, and it's kind of a safe area. Many shelters will also use a similar room, or maybe even the same room, for someone who's having a mental health crisis or someone who's extremely escalated. Just a place where they can go and kind of regain control of themselves, kind of come down, whether that's from a mental health crisis or substance use. That could be a room where they sleep and stay all the time. That could be a designated couch. What does that look like? But there are different options around that. And we're seeing more and more shelters that are employing rooms like this. And similarly, shelters like this may often offer supportive communication. They may require that the client create a safety plan based on if they begin to make sure that they're not going to overdose, to make sure that if there's symptoms, if they lose control, that there's some plan there. But very often there'll be some sort of documentation that has to be completed. And then still, they're not allowed to have drugs or alcohol on the property or any kind of drug paraphernalia. Some will say they can't have it visible. So they're not going to search their bags or anything like that. But if we see it, then you're going to be asked to leave. There can't be anything visible. And then there are agencies that are much more permissive, where use is permitted. Sometimes I'll talk to people who will say, yeah, there are these, places in our city where people who use drugs can go, and everyone's like, yeah, use drugs. We love drugs. And I've not really encountered any place like that where drug use was encouraged, but where drug use is permitted. And so you can, in the privacy of your own room or in the privacy of the bathroom, if you are using drugs, you're not going to be dismissed for that. I have not found a shelter that did not respond to selling or distribution of drugs. So if you gave drugs to other people, or if you were selling them, I think in most of these shelters, that would still be a cause for exiting. But substances and drug paraphernalia that are on the property are treated as all other personal property. We're not going to take it from you. We're not going to tell you what to do with it. It's yours. So you can see there's a wide range here. And of course, there are all different combinations of these and what they can look like. You would have to decide as your program, where do we fall on here? The problem with a lot of agencies is they don't establish a really clear protocol and procedure. And so different staff members different staff members respond to people using substances in different ways. And so you might get a staff member who's like, hey, you need to put that away. We can't see that here. And 5 minutes later, a different staff member say, okay, you're out of here. You're not allowed to have that. But making sure there's a really consistent response. So again, how do agencies that serve people experiencing homelessness respond? Some will respond based on a very strict policy. This is our policy. This is how we respond. Others will respond based on the client's presentation, as I mentioned a few minutes ago. Is the client behaving in a way that we can manage, that we can support? Red eyes, smells like alcohol, a little loud. Yeah, we can handle that. We can take care of that. Throwing chairs, screaming, standing on the table. I don't think we can accommodate that, but they decide how to respond based on exactly what the patient is doing, what the client is doing, just as you would with someone who's in a mental health crisis, just as you would with someone who's having a panic attack. Can we as a program handle this? Based on the availability of resources, do we have a room that this person can sleep in and kind of sleep it off, or do we not? Do we have the staff here who can handle what this client is experiencing? Many agencies will make a decision based on the resources they have available to them in the moment, based on their current population. I've worked with agencies that say, you know what, when we have so many children that they're spread all through the building, then we cannot accommodate people who are under the influence of substances. But when we don't have children like that, we can. You know, they determine who they're serving in the moment and make decisions on who they can accommodate. And then based on risk. For this individual, what are the risk factors? And we're going to talk about those. Of course, anytime that we're making a decision based on something other than strict policy, it allows us to be more people-centered. It allows us to tailor our care. It allows us sometimes to serve more people. It also allows enormous room for an inconsistent response, for an unjust response, for an inequitable response. So this is an important part of the conversation. As we evaluate risk, what we're really thinking about is overdose, the risk of overdose, the risk of withdrawal, the risk of uncontrolled, erratic, unpredictable behavior, unsafe behavior, the community impact, and the impact that serving this individual is going to have on your staff. And so we're going to look at each one of these. It is very difficult to determine, based on the resources available in most agencies, whether or not someone is at risk of overdose. It can be very difficult, of course, to tell what someone has taken, how much they've taken, whether that's a typical dose for them. You know, overdose is very subjective. What causes one person to overdose may have almost no impact on someone else based on how often they use, what they normally use. Overdose is not an exact science that you can set up a scale and apply to everyone. It also can be very difficult to tell, does the person have more of the substance upon them? Are they going to go to their room and use more of it? So I look at them and they seem to be at little risk for overdose, but I don't know that they're going to go back and use more. But these are the symptoms of overdose: vomiting, confusion, shallow breathing. Sometimes someone's lips will be blue. Sometimes you can see them struggling to breathe, or it hardly feels like they're breathing at all. If they have chest pains or an erratic pulse, again, that may be very difficult to measure for most agencies. If they're experiencing extreme lethargy, where they are so tired in how they present that they can barely move, that they can't be, that they seem to be semi-conscious or they're unconscious. These are the most obvious signs of overdose. And so we would be looking, ideally, if you were engaging someone and they were not experiencing any of these symptoms and they were not going to be using any more of the substance, you would say they're not at a great risk for overdose. But that's not always the case. And again, you can't always tell how much someone is going to continue to use, or if they're going to continue to use. So overdose is a risk. And is your staff equipped to respond to that risk? Are they comfortable with that risk? We have a lot of information right now about overdose prevention, and which is very good. And so I know even in Kentucky, there's at least one vending machine, Narcan vending machine, and that's becoming more and more popular. I've worked in agencies where they actually didn't allow people to use Narcan, because when you give someone a treatment like that, just like that, every bit of the opioid leaves their system. And so they can begin vomiting pretty violently. They can be very, very aggressive. And as soon as that wears off, if they have a lot of opioids in their system, they can overdose again. And I've seen clients who overdose 3 and 4 times. And so if you give someone an overdose prevention treatment, and you say, okay, good, everyone go back to bed, we're fine, you can actually end up being in a much worse situation. So you have to be very careful about that, although certainly overdose prevention is an enormous tool and resource to take advantage of. It's also important to realize that those who are at greatest risk for death by overdose, one of the categories of people at greatest risk for death by overdose are those who have gone into recovery, they've stopped using, and then they go back and they start using again. They relapse because they very often go back and use the same amount that they were using when they went into recovery, and their body is no longer tolerant to that, and they die. So all of these important things to keep in mind as you're evaluating this risk. And by what process do we evaluate someone's risk of overdose? Are our staff trained to identify the signs of overdose? And what are they trained to do if they see that, both in the moment and long term? Can our staff be prepared to deal with this? Another risk factor is withdrawal. And a lot of people don't know this, that withdrawal can be fatal. Alcohol withdrawal can be fatal. Benzo withdrawal can be fatal. And so you may have someone who comes to your program and says, hey, I'm never going to use again. I'm going to come in here. I'm going to find housing. We're going to pull everything together. And then suddenly they're violently ill. And so being able to understand the signs of withdrawal and being prepared to respond is part of the risk that you have to evaluate if you're going to see people who use substances. Seizures would be the most dangerous, most obvious sign of withdrawal: trembling, inability to control movement, muscle pain, vomiting, extreme agitation, depression, and anxiety. One of the parts of this, because we're going to talk still about behaviors. We talked about that some. I think, again, what are the behaviors associated with substance use? There can be a wide range of behaviors, but how do we interpret someone's behavior and based on what they're doing, determine, is it safe for them to stay here? Can they be a part of our little community today? And how do we evaluate that? And that's a question you're asking with substance use. That's a question you're asking with severe mental illness, right? Based on what we see in front of us, can this person stay here? And how do we evaluate that? And do we evaluate that consistently? And if we determine that someone's behavior is uncontrolled, it's unpredictable, it's erratic, it's unsafe, what do we do? Do we just kick that person out? Do we just always call the police? Do we always call crisis intervention? What do we do? How do we make a safety plan? How do we make a safety plan if we determine they can stay, but we're not really sure? All of this is part of that conversation. Some agencies are really struggling with this question of, if we're using a harm reduction, housing first methodology, do we ever talk to people about treatment? Of course, harm reduction, these are big conversations, and I know that you all have conducted trainings on these in the past, but harm reduction, the idea that we're meeting people where they're at, we're developing a program that serves people and encourages people and supports people where they're at in substance use, where they're at in their mental illness, where they're at in their physical illness. In other words, we don't say, you've got to stop using or we can't help you. We say, okay, you're using, how can we help you? Housing first, that you don't have to be drug-free or alcohol-free in order to have housing. We're going to provide the services to you that we provide to everyone, and your substance use, your alcohol use does not make you eligible or ineligible, right? So under those big philosophies, is it ever okay to talk about treatment? And I think it's important to realize harm reduction doesn't mean that you never talk about someone's options or their opportunities or the risks of the lifestyle that they're choosing. If someone had a job that was really risky, that meant that they were going to be up all night, that didn't have great benefits, that didn't really pay very much, as a good case manager, you might talk to them about that. You know, I just want to be really clear that you realize with this job, it's going to be hard to it's going to be hard to meet your goals. Or with this job, it's going to be hard. You know, these are the risks. These are the opportunities. We can do the same thing with substance use. You know, with the substance that you're taking, I just want to be really clear. Do you know these are the risks? Do you know that this substance may affect your ability to meet these goals? Just want to make sure that we have that conversation. And we don't have to, we don't have to be embarrassed about that, or that's not pressure. It's just, we're simply talking about the reality of the decisions you're making on all levels, in all areas of your life, and how they can impact your goals. And then creating a safety plan too, with people with anyone who's doing something that could potentially be life-threatening, that could potentially affect their relationships or their ability to stay there or their ability to find housing or their health. A safety plan would always be something helpful to talk about. And so there's nothing wrong about having those conversations, conducting those steps with someone using substances and feeling like, well, then that's not harm reduction, because that's not the case. If you do have someone that's seeking treatment or that's interested in treatment, there's some important things to remember. Sometimes agencies will go, okay, you want treatment, great. And they'll gloss over some important details in that next step. One is that there's inpatient care, there's outpatient care, and there's intensive outpatient care. So if you're a program that refers someone to inpatient care, are you going to allow them to stay there until they go? Are they going to be able to come back to you when they come out? If they're doing outpatient care, can they stay and engage your program while they're receiving that care? If it's intensive outpatient where they're somewhere all day, are they still going to, so it's important to make sure that if you're going to recommend these treatment options, that you understand how the services you offer align or don't align. A lot of people will use therapy as a treatment option. A lot of people will use programs like Narcotics Anonymous or Alcoholics Anonymous, different programs like that. Some will do some combination of that. A lot of people will use medication-assisted treatment. So a big part of this conversation is, how does your program feel about medication-assisted treatment? If someone if you encourage someone says they want treatment, you support them in that, and their treatment involves taking a dose of an addictive substance or of a substance that you wouldn't typically encourage someone to take, how do you feel about that? And so that's a really important, that's going to become more and more important that you understand how you respond to that as an agency. If someone just wants to quit altogether, they just say, I'm never taking it again, understanding withdrawal and what support you may need to offer. And then of course, there are all different kinds of holistic treatments too. And so understanding again how your services align with these different treatment options is really important, and talking about that as a team. Again, withdrawal can be fatal. As you're supporting someone who is interested in treatment, it may be really important to consider, why did the person begin using substances? We had a lot of people who came to detox and they stopped using, and they were in unimaginable pain because they had started using as pain management. And we had many clients who said, I'm now realizing that I'm going to be in pain for the rest of my life, and that the only way to be totally pain-free would be to take these substances that I no longer want to take. And that was a huge, huge decision for them. Or to decide, I can't live this way, I'm going to take these substances because it's the only way I'm pain-free. They may have started using substances because those important to them were using them or encouraged them to use them. The substance that they use, or their substance use, really may be a foundation of their community, like we talked about earlier. Their whole support system may be based in community that they receive from people who use substances. We've had clients that their spouse, their parents, their in-laws, their coworkers, everyone used substances. And if they wanted to stop and back out of that, they were going to lose every relationship they had. If that's true, are you prepared to help to support them through that, or to help them get the support they need through that? Another big part of this that a lot of people forget is that many programs require, more and more now, as we're seeing an infiltration of fentanyl and other substances, that many treatment systems require that a patient go through detox. And so you have someone who's like, I want to go to treatment, I want to do it, I'm going to get this done. And you find this, great little facility where they can go and receive the help they need. And then they realize, first, I've got to spend 2 weeks in a hospital, laying in a hospital bed, or laying in a hospital room with 12 other people. And it totally throws them off. And so it's important to take that and to know that, and to know what the detox options are and what programs require that if you're going to make referrals. And then what if they change their mind? Are they still eligible to receive services at your program? If you do all this work and you do all this support and you send them to treatment and they go and they come back 2 days later, how do you feel about them? It's important to know. Other considerations, we talked about evaluating risk, and we talked about the fact that it's really difficult to evaluate risk, and you need to know that and be prepared. There needs to be staff trainings. There need to be others who come in and offer trainings. Presentation can change very suddenly. If you're deciding to offer care or services based on how someone presents right in front of you, then you need to be prepared for the fact that someone who's using substances can change very quickly. Understanding the difference in your philosophy of how do you feel about someone who's using substances versus someone who's distributing them or selling them. How do you feel about someone who's using substances versus someone who leaves dirty needles or other medical hazards that are associated? It's important to talk through that and to be consistent in how you're going to address those things. Another big thing to consider here is that there are many clients who may come to your program and who have children. And if their children have any exposure to drugs or drugs paraphernalia or people using drugs, they will lose custody. So that is a big element to talk about. Child endangerment is a huge part of this conversation. I do totally separate trainings on that. But what do you do with the children in your program if you're going to have others who are using substances? And then justice system requirements. There are people who, if they come to your program and they're exposed to substances, they could go back to prison. Sometimes, as a requirement of parole, people will be required to avoid others who are using substances. So understanding that and taking that into consideration. Also, what is your mission? What is your mission? And how do you develop a policy that aligns with your mission? What is mandated by your funders? What do your funders require around this? Do different funders require different things? How your community, your funder community, your volunteer community, how do they feel about substance use? That's really, really important to know. What's your target population? What is the composition of your staff? What resources are available in the community? What are the services you are committed to providing, and why did you pick those services? So really having a strong understanding of who you can help and what your partners require. I've worked with agencies who decided to serve people a really robust harm reduction policy and decided to serve people experiencing using substances, and they lost every partner they had, and they lost half their funders. They lost some of their staff. What are the ramifications of this? What kind of education can you do? What kind of conversations can you have? And then lastly, I think it can be really helpful to take some time personally and think about, what do I really believe about substance use? What do I assume about people who are homeless and use substances? When I pull up to a stop sign and I see someone who is, he's got a bottle of alcohol there, he's talking to himself, he has every sign of being inebriated, and he's homeless, he's chronically homeless. What do I think? What do I say to my children in the car? In my gut, what are the things that I believe and assume? Do I need to challenge those? What is my personal experience with substance use? How is substance use part of my story, and how does that affect me? How does the topic of substance use make me feel? What is the position of my agency, and can I support this position? Moral injury, right, is a big part of this as well. So that is the end of our formal presentation here. We have a very few minutes left, so I do want to note that you'll get some resources and that you'll also have my email address, but that you can reach out to, and I'm happy to talk more. I'm happy to answer questions over email. That's no problem at all. But anything else that you think we should talk about in our last few minutes here? Did we have any questions that were sent in? Oh, sorry, I can't hear you.
Yeah, just realized that. I don't have any in the Q&A. If anyone wants to type any questions in the chat, please feel free to do so. We have just a few moments.
As we close out today, I realize this is a big topic. I hope this has given you a lot of things to think about and to talk about with your team, with your funders, with your volunteers. I hope it's given you things to talk about even with your own support system. And you will receive a list of resources, all different kinds of resources. And we are really happy to provide more resources too. So again, if you want to talk more, if you have questions, please feel free to reach out to me. My email address will be in the list of resources too. And I'm happy to support you in as you move forward in this conversation too.
Thank you so much, Cindy. As always, it was an incredible training, very informational, gave us lots to think about. And thank you again to our audience and to our sponsor, Anthem Medicaid, for allowing us to host this training today and this webinar series. And for those of us who have been following the series, we will be hosting another one of our series on Wednesday, January 18th at the same time at 12 p.m. And I believe that Cindy will also be our trainer for the next series.
This one will be on severe mental illness, I believe, and Katie League,
Correct.
the National Healthcare for the Homeless Council, will be hosting that training, and Katie is awesome.
Great. That's wonderful. So my AirPod just fell out. I apologize. But thank you all, everyone. And I hope that you all have a wonderful day, and thank you all for joining us. And we will see you all next time. Thank you so much. Bye.